Hello and welcome to our PKD Awareness Day Ask Me Anything session. I'm Susan Bushnell, President and CEO of the PKD Foundation, and I'm honored to be here with two experts in the PKD field, Dr. Vishal Patel and Dr. Fawad Shabib. Dr. Patel, why don't you go ahead and introduce yourself?
Okay, thank you for having me, Susan. My name is Vishal Patel. I am a nephrologist by training, but I spend most of my time doing preclinical polycystic kidney disease research. I run an NIH-funded laboratory for now over 15 years at the University of Texas Southwestern Medical School in Dallas, Texas. On my free time, well, I'm kidding, I have no hobbies, very little free time. So outside of my work at UT Southwestern, I wear another hat, and that is the chair of the Scientific Advisory Committee at the PKD Foundation. I've been associated with the foundation in various roles over the last 7 or 8 years, and the most recent one being the chair of the Scientific Advisory Committee. So I'm excited and delighted to be invited to this session. Thank you.
Hi, and thank you for having me as well. Thank you, Susan. Thanks for the introduction as well, Vishal. So I'm excited to be here. I'm Fawad Shabib. I'm one of the nephrologists at Mayo Clinic in Jacksonville, Florida. Also, most of my time is spent on PKD clinical care as well as PKD research. So we have a large PKD clinic that I'm directing with the help of many of our colleagues here on campus, and also a large research team expanding from clinical research, looking at various clinical questions, natural history of PKD, prediction of outcomes of PKD, as well as translation and basic science research, and hopefully to be as successful as Dr. Patel in getting funded basic science research as well. And we also run clinical trials. One of them is what Dr. Patel has discovered in his lab, and we're excited about that. And I'm sure we'll be talking more later today about this. And similar to Dr. Patel, I don't have much free time, but in my free time, I also help the PKD Foundation in various roles. So we've been helping with the Centers of Excellence and co-directing that advisory board, as well as being on the board of director of the PKD Foundation, which is I'm very proud and honored to be there. So thank you for having me.
If I may quickly add, he does live close to the beach. So, but anyway, sorry.
I do go to the beach sometimes, yes.
Well, thank you both for being here to share your knowledge and your insights. Today, we're going to dive into some of the most pressing questions and topics around polycystic kidney disease. We've collected several questions from our community, covering everything from general PKD knowledge to the latest research updates, and our experts here will provide their insights. Before we get started, I'll just say that I'm going to be asking these questions as we receive them. So these are directly from the larger PKD community. But let's go ahead and get started. What exactly causes cysts to grow? And do we know what expedites that growth?
Maybe I'll get started and then Fuad can expand on it. So unlike many other chronic kidney diseases such as diabetes, hypertension, which are pleiotropic, multifactorial, and we don't clearly understand where the race or the disease process starts. That is not the case with polycystic kidney disease. It is a monogenetic disease, which means we know what the pivotal seminal event is that causes the cyst to grow, and that is mutations in one of two genes, for most intents and purposes, one of two genes, PKD1 and PKD2. And so what happens after that causes cysts to grow? A bunch of things. And so I'm not going to bore you with the things that happen downstream. There are many pathways that get dysregulated because the PKD1, PKD2 genes are dysfunctional. The main ones I'll point out would be cyclic AMP pathway, which is targeted by the drug tolvaptan that is currently FDA approved. There are other pathways such as mTOR pathway. These are all pathways that turn tubule cells, kidney cells, into an hyperproliferative, hypersecretory state, making the kidneys and the cysts to grow. But I think the takeaway message is that what does cause it to grow, it is the mutations, PKD1, PKD2. Do we know what expedites the growth? I'm going to go back again to the mutations of PKD1 and PKD2. We know quite a bit about what those mutations do to the subsequent growth of kidney cysts and kidney and ADPKD progression. So in general, thought that PKD1 mutations are a little cause disease progression a little bit faster than PKD2 mutations. So that's the first distinction already in terms of what are characteristics that get the kidneys to grow. Second, amongst PKD1 mutations that kill the gene are worse off than the ones that reduce the function. So all mutations reduce the function. One may severely disrupt it. Others may reduce it to a certain level. And so again, that dosage seems to be very important. And so that's what I have, and I'll let Fuad chip in.
Thank you. Yeah, that's a great explanation. I think you touched on all the various aspects. I might just add that in the same kind of role of cyclic AMP, with PKD, there's the kidney cysts are a little bit more sensitive to the vasopressin, which is the thirst hormone or water hormone. So when that vasopressin or AVP is coming and stimulating the kidney cells and the cysts, it's increasing that level of cyclic AMP. So that said, if we can, the things that could raise or expedite the growth is if we have more of that vasopressin in a way. So we always recommend to our patients to hydrate themselves a lot. So drinking a lot of fluids would help suppress the release from the brain to the kidney of this thirst hormone, and hopefully that would reduce the expedited growth. And then also eating less salt, which helps in a way reducing the need of how much water we need to suppress that water hormone. And then we'll probably talk more about lifestyles such as smoking and excess weight, and all these things could potentially play a role in expediting the growth of the PKD cysts. But again, it's a monogenic disease, as Dr. Patel mentioned, which means it's something that we don't have control over. Hopefully with medications, we can raise the level of these polycystin protein inside the cell, so it could stop the growth of the kidney cyst. But hopefully that's a relatively simple explanation of a very complex disease. So.
Well, thank you both. Next question. I'm one of those rare spontaneous occurrence patients. None of my family members have ever had PKD. Why does this happen? Are there any environmental issues that cause this?
Great questions. Maybe I'll take a stab at that. So we know up to 20% of our patients don't know if any other members of their families have PKD. So the majority, they would know either one of their parents or grandparent has polycystic kidney disease, and they're quite familiar with what happens with PKD and kind of kidney failure, dialysis, transplant. But the other 20%, it could come as a surprise, and it could be very shocking news. So a portion of these 20%, we call, it could be a spontaneous mutation, which means what we call de novo mutation. So then no one else in the family truly, they don't have the PKD. And then that patient during the conception, so when they were in the womb or in utero of their mother, one of the cells developed a change in the DNA. So there's a mutation in the DNA in the PKD1, PKD2, or other PKD genes. And so then as the embryo is growing, these cells have the mutation, and then it develops PKD. So that's the true de novo mutation. But there's a portion of patients that they would think they have no other family members. Many reasons for that. Either they haven't been checked, so the parents have not had an ultrasound, or the parent had passed away for other reasons and couldn't get that diagnosis, or the disease is quite mild that no one else has really needed to know about it or didn't come to medical attention. So we don't think there's a lot of environmental issues that causes these de novo mutations. But I'll also let Dr. Patel maybe add if there's any other environmental issues that you think can cause de novo mutations.
No, I have nothing else to add. It is certainly an interesting scientific question to figure out. And the fact that genes get mutations at a random rate is a known fact. It happens to PKD1, but also happens to other genes, obviously, and why certain individuals are more susceptible versus the others. And those are questions that are open scientific questions, I would say, at this point.
Thank you. What does disease progression typically look like for AD-PKD patients? Typical first systems, what they look like, and the average age of onset through kidney failure?
Great question. So also it's a spectrum. It's a variety of symptoms that our patients kind of present. Again, a lot of patients would have a known family history of PKD. So they're quite aware as they're growing up, they are at risk of having PKD. So in the setting of someone has someone else in the family with PKD, each of the family members would have 50% chance of having PKD. So that said, a lot of our patients would like to know ahead of time. So that's what we call pre-symptomatic screening in a way. So they go to their doctor and they say, my mother has AD-PKD. Could you please check if I have it? So then they go on and they order a kidney ultrasound. And if they find the typical findings, which is enlarged kidneys, multiple kidney cysts on both kidneys, then they have the diagnosis of AD-PKD, and their presentation would be mostly not symptomatic. Now, another group would have either very high blood pressure when they first come in, they come in with a headache, or when they're doing a routine check with their doctors, they see a high blood pressure. They might see low kidney function, so the blood test on the routine exams, the creatinine would be high, so the GFR or the kidney function would be low. Or they come in with gross hematuria, which means one of the cysts has bled and they see a lot of blood in the urine, or pain, acute pain, or infection. So there's a variety of things that could present first. So, and then another group come in for other reasons to the emergency department, or they get an MRI of their back, or they get a CT scan of their abdomen for other reasons, and then they find incidentally the kidney cyst, and they get referred to their nephrologist, and they get the diagnosis. And then the other part of the question is the average onset of kidney failure. So also it's quite variable, and it's quite of interest to all of us as scientists and clinicians. It's we see some patients reach kidney failure in their 30s and early 40s, and then we see also patients who never reach kidney failure. Maybe they're in their 80s and they have just low kidney function and not kidney failure. So Dr. Patel mentioned the PKD1 versus PKD2. So there's on average PKD1 reach kidney failure in their mid-50s to late 50s, and then PKD2 maybe in their 70s. But now we're realizing there's also a lot of granularity in between. So it's quite the spectrum. On average, we say about 50% would reach kidney failure by their early 50s, and maybe 3/4 of the patients would reach kidney failure by their 60s. And then almost all males would reach kidney failure by their 80s. So females are a little bit milder in terms of reaching kidney failure. Anything else to add, Dr. Patel?
No, I think you covered it. Very comprehensive.
How much does genetics impact disease progression versus things I can control, like diet, exercise, and stress?
Well, that kind of goes back to the first question. Genetics versus the environment. If I were to do a head-to-head comparison, of course, this is a monogenic disease, so that genetics is the one that plays the biggest role here. It sets up the stage for the disease to initiate and then progress. But that does not discount the fact that environment also can play a role in determining disease progression. I think Fuad touched on it in some of these initial questions about lifestyle in terms of weight, hydration, smoking, the general things that we do to lead a healthy lifestyle. There may be other environmental factors that may be uniquely help progress or slow progression of AD-PKD. But lot of it is just research and hypotheses at this point. So I wouldn't, take me use this as a direct quote from me. But there are certain diets that seem to be preferentially help towards slowing disease progression, and caloric intake, and things like that. So there is a large area of body of research that is maturing. There is several groups that are interested in understanding how the environment plays a role. But I think it's very difficult to give you a number and say, 60% of the disease progression is because of genetics, 40% is because of the environment. As far as I'm concerned, the main takeaway is that it's the genetics that's the driving force. And as the research matures, maybe we'll circle back with you and tell you of what we think about environment.
Yeah, so that actually leads to the next question. And Dr. Shabib, I'd love to hear you chime in on this one. But are there any ongoing studies being conducted about the impact of specific diets?
Yeah, absolutely. Thank you. So the diet comes often as a very important aspect in our patients' kind of approach to the disease. And I think the main reason is that we as individuals, as patients, as providers, clinicians, we like to change the modifiable risk factors, right? So Dr. Patel mentioned that the main thing is the genetic, the changes in the mutation. And with research and hopefully new medications, we can kind of tackle that with medications. But for now, we think it's a non-modifiable until we get the gene therapies, genetic therapies, gene cures. So that leaves us with the modifiable risk factors. And there's a very solid research from various groups that the more we have excess weight, the faster the kidneys are going to grow and the faster the kidney function is going to decline. And then there's smaller studies, relatively smaller studies, that's showing that if you lose the weight, irrespective of how you lose it, I mean, they tried multiple different strategies, but it seems that if you lose the excess weight, you might be able to help with reducing the growth of these kidney cysts and thus put a little bit of brake on the progression of the kidney disease. So our main advice and the take-home message is, yes, there's a lot of great research that we call preclinical, so mostly on PKD animals and things that are in the lab that are indicating that there's a change in the metabolism of the kidney cells. So there's some sort of reprogramming. And then if you can work on your diet to change that, to reprogram the reprogramming of the kidney cysts, that could be helpful. The data right now is still in the clinical side, which means on patients with PKD, it's still not enough for us to say, okay, I'm going to prescribe this particular diet versus this particular diet. But overall, the data is telling us that if we go back, if we aim for a normal body weight, so body mass index of close to 25, so basically not be overweight or obese, that's going to be the best thing a patient can do to themselves. Now, how do we reach that? That's the question. There's a lot of nice research on ketogenic diet, on intermittent fasting, caloric restriction. Each of them has their pros and cons. The main take-home message is we don't have enough long-term and large number of patients who have been prescribe these interventions and kind of have some head-to-head comparisons. I know there's phase 2 trials. There's more ongoing efforts to try to get to these to be answered. So the more our patients get involved in these clinical trials or clinical studies in diets, the more we get more answers, and then we can apply it more specifically. But again, the take-home message is try to lose the weight, whether you can do caloric restriction, so reduce the portion of your calories. So as you're eating each meal, try to kind of have less of that, maybe by 20% or 30%, and gradually lose the weight if you have excess weight. That's the main take-home message. So diet, exercise, less stress. I know that some patients have asked about that. So
wonderful, thank you. How can we treat PKD-related pain? Are there other methods besides medication?
Sure, I can also take a stab at that. Pain is also another big symptom that our patients have to deal with. I'm quite impressed on the level of tolerance of pain. I mean, they wake up with a chronic pain and they say, "Okay, I'm gonna keep going, no problem." So in comparison to other disease groups, I think our patients have a high tolerance of just kind of they accepted that, okay, I'm going to have a little bit of discomfort, of pain. Now, there's two types of pain. There's the acute pain where there's a cyst infection, cyst bleeding. So those typically are just short term, and most of the times they resolve on their own with the right treatment. So if it's a bleeding, it stops on it. Most of the time, stops on its own. Sometimes we just need to hydrate and give some pain control just in the setting of that acute pain, or antibiotics. Now, the chronic pain is the more challenging. Patients would have chronic flank pain that kind of, sometimes gets worse, but a lot of times it can be disabling and debilitating. And it doesn't have to be that their kidneys are huge. There's sometimes no good correlation between how big the kidneys are and how bad the pain is. So how we approach it is in a kind of stepwise approach. We try to go first with conservative measures. So sometimes heat pads, or just taking some Tylenol, and do some exercises to strengthen the muscles of the back. Then we kind of there's some interventions when it becomes debilitating. So sometimes we burn the nerves that goes to the kidney. Sometimes in select patients, we remove the fluids, we aspirate the fluids, so there's less of these big fluids causing these. And then other times we do kind of additional interventions, like spinal cord stimulator and other things. It is a journey with pain, and it involves having multiple people who are expert in pain and understanding it, because it's quite complex. And the first step is to really acknowledge that PKD can cause pain, even if the kidneys are not big. Sometimes just having those kidney cysts will add more pressure on the muscles of the back, and it does take quite a bit of effort to have that taken care of.
I'm gonna jump to a question because I feel like it's related. But what are the pros and cons to draining cysts?
Yeah, so we typically don't like to drain these cysts unless, again, there's a lot of pain, there's a lot of symptoms. So we don't think about draining the cyst to improve kidney function, although there's some small studies that show that if we remove this fluid from the cyst, the kidney function maybe has improved a little bit. But again, it's a procedure. So intervention radiology would go in and take a needle, get it to the kidney cyst, aspirate the fluids, and inject something to burn the lining of the cyst, so it kind of collapse. Those interventions also are not long lasting. So in our hands, the pain can improve, not completely, but can improve. And it lasts about 1.5 to 2 years. And again, it's important to have an expert group of radiologists, intervention radiologists, who are doing this. We typically choose wisely the patients to make sure that they're going to get benefit out of this procedure. So typically it's patients who have very large cysts, and if we drain 3 or 4 cysts, it's going to help with reducing the volume of the kidneys. The disadvantage is sometimes the pain doesn't improve. Sometimes we get rarely complications like bleeding within these cysts, or we've never seen in our hands infection, but that's something that could happen. We do the same for liver, and also we've had good success with that, and we've had one complication related to liver. So it's important, again, to choose wisely and in collaboration and with the radiologists to help us with these. So it's a procedure with some risk. It's not without a risk, and it's not for everyone. So again, going to the PKD centers of excellence or other places where they're familiar with this type of intervention is important.
Given that there is now an association noted between PKD and brain aneurysms, why aren't all individuals with PKD screened for brain aneurysms?
So in terms of aneurysm with PKD, there is a high risk. So in general, as a general population, we're all like if we take 100 individuals from our society, about 3 of them would be walking with a brain aneurysm without being aware of that. Now with AD-PKD, the risk is higher. It's kind of 8 to 9%. So 8 or 9 out of 100 patients with PKD might have an aneurysm. The highest risk is when someone within their family has also an aneurysm. That risk jumps almost close to 20%. Now, in terms of screening, there's been a debate. There's no consensus. Should we screen everybody all the time? How often? Or should we screen high-risk patients? So I don't think there's no consensus yet on this. Our approach, I think in the United States, most of PKD experts will agree that targeted screening is the right approach, which means screen patients who are at high risk, which means if they have a family history of intracranial aneurysm or sudden death or brain bleed, or if they have high risk occupation that could jeopardize lives of others, or before a major surgery, or if the patient really wants to know and they're worried about it. So that's kind of what we recommend to screen. And the screening interval would be, if we don't find any aneurysm, is between 5 to 10 years. So depending also on the risk factors. So in other words, we don't screen everybody and we don't screen every year for brain aneurysm. The reason is the aneurysms that we can find in pre-symptomatic screening. So if someone comes to our clinic, they're feeling fine, we just want to know if they have it or not. Those aneurysms tend to form and they don't rupture quick, which is great. So the aneurysms that don't rupture tend to form and then slowly grow. So we can kind of detect them reasonably within those 5 years intervals, versus the ones that form. So there's another subgroup that the aneurysms would form, and then within a year they would rupture. There's some studies kind of simulating how that happens. So the ones that form and rupture are kind of very, very hard to detect them on screening, because within 6 to 12 months, most likely they will rupture and they will present with a very severe headache, what we call thunderclap headache, a headache that they've never had in their life, very, very, very severe. So we educate our patients to go to the ER as soon as they kind of feel something like that. But if we screen everybody, we will have to do it every 6 months for everybody to be able to detect these. And even with that, we might be missing those that would rupture. So it's kind of a balance between worrying patients about aneurysms, and then if they find something also that's small in size, let's say 2-3 millimeter aneurysm, that we know that it's very slow to grow. Sometimes they never grow. So also having that diagnosis is a big burden on our patients, and we balance between kind of knowing these and then doing interventions on these, because also if we go in and do these coiling and other things, those interventions have their own risks as well and have complications and comorbidities. So it's quite of a multidisciplinary approach, again, working with our neurologists, neurosurgeons, to let's say if we screen someone and they have an aneurysm, how do we approach that? I think it's important to have a group of specialists who are dealing with this and advising our patients on that. Anything else, Dr. Patel? Hopefully I covered everything.
No, I think you covered everything. I just wanted to emphasize a couple of points that he made in his very elaborate discussion. First is that yes, the risk of aneurysm is higher amongst people with AD-PKD compared to the general population, but it is still relatively low amongst the AD-PKD patient population. I think Fuad quoted a number of 8% or something like that. So that, it's not terribly high. That's point number one. And the other point that I wanted to make was that yes, indeed, there is no consensus in terms of how to screen for people who do not fall in the risk category. The approach that we've used is that if someone is truly very wants to know and is truly concerned about it, even though they may not fall into the high risk category. We would offer it to them.
Absolutely, yes. It's important to offer it for those who would like to know. Absolutely.
Wonderful. Thank you both. Shifting a little bit to transplant now. What happens to your PKD kidneys after a transplant? Do they stay big? Do they shrink?
Also, very, very nice question. We've looked at this actually in our group, and we showed that the kidneys shrink after transplant. So they do get smaller. And that's something we take into consideration when someone has a lot of pain or they have moderate pain and they're considering to take their kidneys out. So we kind of balance between, okay, these kidneys might shrink and maybe have less pain after transplant, or is your pain so severe that we have to consider taking the kidneys at the time of transplant or right after transplant? So they do. For the most part, they do shrink, and they shrink significantly after long years after transplant. Yeah.
Okay. After transplant, how will PKD continue to affect my body?
Fuad already talked about how PKD will continue to affect the kidneys. But from a kidney function standpoint, because now you have a new donated kidney, typically speaking, the function should now, kidney function, at least from a creatinine and a BUN level standpoint, should normalize. But remember, this is a systemic disorder, which means all cells of your body, in addition to the kidney cells, have mutation in the PKD1 or the PKD2 gene, whichever one is relevant to that individual. And so while the kidneys may be taken care of, other organs that are affected by ADPKD, I mean, those need to be, we need to be mindful about that. So liver is probably one of the biggest. The next one, where individuals do end up getting liver cysts, and that is with kidney transplant that doesn't go away, and so that's something to keep in mind. And then there are other organs that are affected, heart and blood vessels and things like that. So. That's the way I would say that it affects the kidney. Now, the good news here is that the big issue with PKD mutations is indeed kidney failure, and so that really has been taken out of the equation with the kidney transplant. So while the mutations continue to affect the rest of your body, the transplant does really fix the atrial pancreas in the room. Fuad?
Yeah, I agree with you, Dr. Patel. The other thing is we talked about brain aneurysm. I think we should still continue to screen as needed, taking into account age of our patients and other comorbidities. But for the most part, we shouldn't forget that the risks are continuing for the other organ groups, as Dr. Patel mentioned.
Well, thank you both. What is the latest update on artificial kidney research?
Okay, so there has been quite a bit of interest, as you can imagine, not just from a PKD perspective, but from a broad kidney disease perspective, to produce artificial organs that can satisfy the large need for kidney transplants. People spend unreasonable amounts of time waiting for kidney transplant, and so this is the basis for doing the artificial kidney research. I would say, without getting into too much depth, first of all, I'm not an artificial kidney researcher, so you could consider me a layperson. But I would say that most of it is still preclinical. There has been quite a bit of uh, fundamental advances in, for example, growing kidney in a dish, or making a bioengineered organ where you make a scaffold of a kidney and then grow cells in it and see if it will work, and things like that. But it is still I would say not ready for prime time. That said, we didn't have an ability. We didn't have the ability to grow kidney in a dish even 10 years ago, and so this is really new area of research, and people are kind of figuring out the initial issues. For example, for the kidney in the dish was they would be able to get a kidney to grow, but it resembled an embryonic kidney from very early stage mouse, for example. So that clearly cannot suffice and replicate the adult function. The other issue was that these kidneys grew in this dish, but they never had blood vessels. And so without the blood vessels, how are you going to get blood into the kidney, which needs to be purified? So these are all challenges that people are figuring out. Now there are vascularized kidneys in a dish, and so I think the field is moving forward. I do want to, even though the question does not directly ask about it, I do want to mention, since it's kind of related, about the excitement that has been around in the kidney space about xenotransplantation. So it's not artificial; it is actually real kidneys, but from animals. So pigs, for example, and many of you may have read articles in the New York Times and the Wall Street Journal about individuals who had really bad end-stage kidney disease, not good candidates for kidney transplant, or multiple transplants in the past, couldn't get new kidneys and things like that, who have undergone these experimental procedures and have done remarkably, surprisingly well. So a lot of stuff is happening in that space as well, and that's one space that I'm very excited and looking for more information, more trials to happen. So bottom line, many things are happening that are exciting, and that is sort of my hand-wavy way of giving you an update on artificial kidney research.
Thank you, Dr. Patel. Yeah, this I know a lot of our patients ask this question about artificial kidneys, and I agree with you. It's not prime time yet, and I think to be able to get to that prime time, we need much more resources and bigger teams, and to get there, it's quite complex. But I agree that the excitement should be shifted, or for our patients and us, is shifted towards the transplanting a kidney, gene-edited kidney from a pig to a human, and I think that would only go. It will expedite. It will be in our lifetime where we have, with patients come in, they don't have a living donor, we'll be able to grow a kidney specific for them in the lab, bring it back. I think that's going to happen. There's no way around it. I think it's going to happen. Not to give false hope, I think that's going to be happening, since we saw these big milestones happening recently. I think we'll only get more advancement on that front.
Thank you both. What is the latest update on gene therapy research?
Okay. All right, I'll take a stab at that one as well. So, at the start of this conversation, Susan Ford, we said, look, your majority of your destiny as far as the PKD research is, polycystic kidney disease is concerned, is determined by the fact that you have the genetic mutation. And I think we may have used the word unmodifiable because that's what you have. You can modify the environmental factors, but not this. But I want to flip that, perhaps a slightly, a pessimistic view about it, to a more optimistic side, which is that at least we know what the issue is. And in fact, that is the most exciting part to me, which is that now No, it's not that we may not be able to, that's your God-given hand and that cannot be changed. No, things are changing. We can perhaps, change that. So I will give you a little bit of what my sense is that's happening in the gene therapy research that is outside of polycystic kidney disease, and that kind of tells you what may be coming next to our own field. So many have said that we live in a golden era of biotechnology with tools that keep changing on a daily basis and give us the power to edit our genomes at will. Essentially, we are not talking about cutting and pasting. We are talking about a pencil and eraser sort of technologies. You can go in and write in an A where there was a G, or you can go in with an eraser, rub off the G and write an A. That is the level of technology that is advancing. This is indeed CRISPR and base editing approaches that I'm talking about. There was a program on 60 Minutes a few years ago. Google, look up those videos and that kind of give you a little bit of an idea of what I'm talking about. So those technologies are not sci-fi anymore. There are numerous biotech companies that have been formed to harness that technology, and that has now progressed into clinical trials in people with various genetic conditions, hypercholesterol, familial hypercholesterolemia. These are individuals who have such high levels of cholesterol that they cannot be controlled using regular medications and need genetic maneuvering. Sickle cell, thalassemias, and a bunch of other monogenic diseases. And so one way or the other, I can predict how and what will kind of align in ADPKD, but one way or the other, this is coming. I mean, we are, we're going to be there. If we get back to a little bit of more specific in terms of PKD, there are challenges now in terms of applying gene therapy to polycystic kidney disease. And, we need to be mindful of that. And that means more R&D is needed. That doesn't mean there's no hope. No, there's hope, but there are questions that need to be addressed first. Unlike the diseases that I just mentioned, sickle cell and hyperfamilial cholesterol hyperphosphatemia, ADPKD, and specifically PKD1 gene, is one of the largest genes in the human body. And so it is not as easy to tackle that as opposed to, let's say, tackling some of the other ones. So that's point number one. Point number two, gene therapy approaches are injected in your body into the bloodstream, and then they go to the organ that is affected. Delivery approaches need to improve such that they can be targeted to the kidney. For now, I would say it is mostly focused on other organs, although there has been excellent strides that have been made in terms of using delivery approaches that go to the kidney. So that is second big challenge. Third, correcting mutations. That has been one of the things that have been applied in other diseases. Well, there are thousands and thousands of mutations in the PKD1 gene, and so that is, picking which private mutation, what the regulatory landscape would be, how would we even test it out, and those are questions. I want to again say these are not hurdles that cannot be surpassed. These are questions that we need to think about, and so I don't mean to give a view on it. In fact, I'm perhaps the most optimistic about this. Before I move on, I will say these are questions we would not be talking about 5, 6, certainly not 10 years ago. That was not even a point of discussion. So it's truly an exciting time. The one approach that perhaps we can think about in terms of gene therapy is that, remember, we mentioned at the top, one copy of the gene of PKD1 or PKD2 is mutated. But individuals also inherit a normal copy that comes from their unaffected parent. This indeed is the reason why we call it autosomal dominant disorder. One copy is enough to give you the disease. Turns out many cells in the kidney continue to express the other normal copy. And so, harnessing that normal copy essentially to compensate for the one that is gone is in essence doing gene therapy. And so that is something that I would say would be the easy first pass towards cracking into the gene therapy toolbox for ADPKD as we and then as we get more experience and as we have newer, cleaner tools, we then start perhaps moving into the area where we now think about correcting the defective copy as well.
Well, thank you so much. That's great. I know you're at the forefront of this, Dr. Patel, and we appreciate you in the field that you're helping our PKD patients in trying to get novel therapies where you tackle the center of the problem, which is having less of that polycystin protein and how we can raise that. I agree. We're at the kind of a crossroad of very great advancement that we can see again in our lifetime, hopefully, where we can imagine someone comes in and they're like, let's say 15, 16 years old. We inject a therapy, a CRISPR editing type of delivery to the kidney, and then you fix that. Sometimes it's only, as Dr. Patel said, it's only one base or one small change in the DNA that needs to be erased and then changed. So you do that, and then the patient doesn't have to worry about kidney cysts, kidney failure, and what have you. So that hopefully would be something that we would see within, I don't know, what do you think, Dr. Patel, within a decade or so, hopefully?
Certainly in our lifetime. We both look young. We were kind of old. I don't know. I'm old. He's very young. But so even in my professional career, I would say, and so it truly excites me about this.
It's very exciting, and hopefully we can, as I always say to Susan, align the stars to accelerate this, right? So we don't want this to happen in 20 years. We want this to happen for our PKD patients, take that technology from other diseases and apply it to PKD, which means there's a lot of nuances particular to the kidney. You mentioned the delivery. Most of the times when you inject those, it goes to the liver and doesn't get to the kidney. So how can we overcome this hurdle? I think we have to put more resources, which means funds, but also the right minds together as a multidisciplinary, get kind of the best minds in the field and work on the top questions. And I think our patients can play a big role in that, and through that the foundation. So I think it's very exciting and more to come. Hopefully year after year, you'll have some more solid things that we can actually share, not just the vision.
Wonderful. Thank you both for that. I guess I'll follow it up with just the last question here, outside of the gene therapy that we talked about, but what additional promising research is out there that is pointing towards a cure for PKD?
Sure. Well, I think the most exciting is what Dr. Patel has in his up his sleeve. So, or at least the closest to getting translated. And by that, I mean, there's the anti-microRNA that's being now in phase 1B and hopefully soon in phase 2/3. So that's not maybe Dr. Patel can correct me, but that's not the pure term of cure, because we're not going to change the DNA, but rather one small step down to that. But that's closer to be kind of a genetic treatment, genetic therapy, rather than a gene therapy or gene cure. There's a little bit of that nuances there. I think, again, as Dr. Patel mentioned, there's an FDA approval to a CRISPR editing gene therapy to sickle cell, right? So there's at least one big milestone there. And I know that the companies that are working on these particular gene cures are also starting to get invested in PKD. Potentially, there's a polycystin corrector where the proteins are not getting to the right place. There's some treatments that are being publicly announced. Hopefully, I'm not announcing anything non-public. Publicly announced that they're gonna they're developing something that could treat select patients depending on their mutations and what have you. Select PKD1 patients, and I think there's others who are interested in this approach as well. Again, I think if we can deliver to the kidney in a meaningful way, deliver these therapies, I think that's in my mind, the biggest hurdle. And I think there's hopefully promising research there, where it's not just looking for delivering gene therapy to PKD, but other kidney inherited monogenic diseases. So through these new delivery models, hopefully more biotech comes and also academic scientists help in that as well. So more to come again. So Dr. Patel.
Yeah, I'll just expand this question a little bit to perhaps say when you say most promising research plan towards cure of PKD, I will include recent data that have come out of mouse models, and that's promising research. So believe it or not, so we know that it's PKD1 mutation, PKD2 mutation caused the disease, right? So genes are gone, the disease starts happening in mouse models. Believe it or not, we did not know until 3 or 4 years ago that could you give back PKD1 after disease has established itself, severe disease has established itself, and will giving back PKD1 at that point have any impact on disease? In other words, when the barn is open and all the animals are out, can you simply close the door and automatically all the loose animals will be back inside, meaning you've kind of closed the barn? Surprisingly, stunning results from investigators at Yale, where they gave back PKD1 in a model that had severe disease and that shrank the kidney. We've found similar results. Our work came out around the same time, where we pharmaceutically increased PKD1 levels, and that also seemed to work really well in mice. And so what that has done is that it has opened the eyes to people, or drug developers, academicians, of the fact that PKD1 is a bona fide drug target in ADPKD. It was like, yeah, of course it is, but data needs to be there, and so now we actually have foundational data on which people can develop assays to produce drugs and work out. So the most promising research that I think is pointing towards cure for PKD is a bunch of different approaches that are being targeted towards genetic root causes of PKD1 and PKD2. And this is not hyperbole anymore. It's simply based on well-done studies where people have shown that the disease can be regressed, at least in mouse models, or the growth can be flatlined and things like that. So that I think is truly exciting. That said, there are other things that are promising as well. I mean, it is a complex disorder. There is an immune component to it. There is a metabolic component to it. And all of those axes are being actively investigated and have shown very promising results in mice and cellular models, and are moving closer to translation. I think there is a trial, human trial going on where they want to change the metabolism in individuals with ADPKD using some specific drugs. So quite a bit of exciting, quite a few promising things that are, I think, coming online. The biggest change that I think has happened, because I write grants and they all get rejected all the time. But the big question that everybody now wants to know, which is a great thing for the PKD community, is if I am saying that this is a drug, or this is a thing to target in polycystic kidney disease, everybody first wants to know, how is this thing connected to PKD1 and or PKD2? Is it 1 degree of separation? Is it 6 degrees of separation? And that level of proximity is not, the bar in the past. And so we've moved at least, from a thought process standpoint in that direction. And that just tells me that we are going to learn immense amount about what happens what are the key proximal events that happen after PKD1 and PKD2 are gone, and that is going to open up a whole host of things that we can target that perhaps could, if not cure, certainly stabilize disease progression. Yeah.
Wonderful. Well, thank you again, Dr. Patel and Dr. Shabib, for your time, your expertise, and dedication to our community. Your insights today have been incredibly invaluable, and we're grateful for the work you continue to do in advancing research and care for those affected by PKD. Before we close, if you're looking for a way to get involved with the PKD Foundation this PKD Awareness Day, consider sharing your personal story on social media or sharing one of our PKD facts to help raise awareness, educate, and inspire others with PKD. We know how important it is to stay informed and connected, and we hope that today's session brings you valuable information and a sense of community. Thank you for tuning in and for your continued support of the PKD Foundation.